Hello and welcome to another show of MEDtalkx. This is a regular show covering a range of topics with a focus on health and well-being. It is being broadcasted live, so if you want to see evidence that we look better than we sound, so please go on YouTube and search for MEDtalkx. That's MEDtalkx with an X. We're also broadcasted live on Pendle Community Radio, Awaz 103.1 FM. So that's exclusively live on there. So you are joined by myself, Mehran, and my co-host Faheem, and we are also in the presence of guest Dr. Seby and Mr. Abdul Rahman to discuss the importance of dental care and broadly how it's currently being managed given the current lockdown restrictions. I guess some housekeeping. Just be mindful that any advice that we give out doesn't replace the guidance from your own dentist. So if you have any problems with your teeth, please do get in touch with your dentist. Over to you, Faheem.
Thanks, Mehran. Thanks for the lovely introduction, as always. I'm going to do a disclaimer. These two I know from before university days, so it's really good to always catch up with old friends. A bit more introduction to our guests who've given up their time tonight. We have Dr. Suhaib Mohammed, affectionately known as Dr. Seby to us, or Seby. He's a principal dentist at Hewetts Dental in Brighouse. And he graduated back in 2004 with honours, no less, from the University of Sheffield. And he's worked at the practice for over 10 years there, quite experienced and well acquainted with many things, with a particular interest in cosmetic dentistry, in particular 6-month smiles to straighten teeth as well. And he's undertaken numerous courses since leaving university, and he's keen to develop his skills further in tooth wear and full mouth rehabilitation cases. So I'm really warm welcome to you, Seby.
Oh, thank you. Thank you for having me. It's been a long time since university, but 2004, it seems like ages ago.
Absolutely. And also, I can't neglect our other very important guest as well. We've got Mr. Abdul Rahman El-Mugi, and he's a consultant and specialist in restorative dentistry. I'm sure we'll find out a bit later on this evening what that exactly means for our public. Warm welcome to you, Abdul Rahman.
Thank you. I qualified in 2003, so it feels even longer than Seby. So it's like a long time that we're all for each other. So yeah, very good to see you all again.
A show for the oldies, I guess, tonight. Okay, so Seby, without further ado, let's come to you first, please. So just a bit of background, really, I guess, for people who are listening in. Obviously, you became a dentist. Do you want to tell us a little bit about what got you interested in dentistry, getting into it? What does being a dentist involve?
Yeah, from being quite young, 12, 13, I was interested in science, how things worked, biology, chemistry, those sorts of areas. And like any other typical Asian, they see the parents push you towards the medical field. So on the cards was either becoming a GP or becoming a pharmacist. And in the background, unknown to most of our elders at the time, was dentistry. Dentistry was kind of up and coming on the horizon at that time, 2000, around the year 2000, 1999. And it was my wife at the time. She was my girlfriend at the time, but my wife who then convinced me to do dentistry because she was following that suit and we could both do it together in a joint university. And that's what we did at Sheffield University, essentially. Got married later and the rest is history, as they say.
Great.
Wow, it looks like love has no bounds.
Yes, it was really helped convince me to do it. I could have done pharmacy, I could have done medicine possibly, and I don't want to start a fight between medics and dentists. You know, this is an old war that's been going on for a long time. You know, we know we're second best. You know, we'll accept that. But we work 9 to 5 though. We work 9 to 5.
No, we're all equal on this show. Well, what about you, Abdul Rahman? Is that a similar journey for you? Or?
It's a similar background, really. I mean, I was quite fond of sciences and languages, and I did a combination of both for A-level, with the Spanish, chemistry and biology, alongside general studies. And I just saw that there were more kind of solid career prospects out there doing a vocational degree at university rather than a language degree. And it doesn't mean that I cannot carry on with, you know, the hobby of languages alongside having some sort of profession or some sort of vocation at the end of it. So that was really what pushed me into it. My father was a doctor and he advised me not to do medicine because of the hard work that was involved, and that dentistry was an easier career. Whether that's the case or not, it's arguable. But yeah, that's how we end up where we are.
Great. So
excellent.
Go on, Faheem. You're about
Seby,
to say
I guess, yeah. Yeah, Seby, I guess we want to know, with a background completed, really, if you can tell us a little bit about how this pandemic's been affecting your work and the workload. And I gather dentists are back opening again next week, aren't they?
Wow. Yes. So next week is a significant date. I think it's the 8th on Monday. Those are guidelines set by the government that allows us to then go back to practice. But I mean, it's been a tumultuous period, really. Absolutely crazy. I mean, for everyone, not just dentists. I'm sure everybody has been affected in some way or another. But yeah, I mean, it's hard to social distance as a dentist. You know, you have to break that barrier. So for us, we really are at the forefront in terms of being exposed, and the protective measures that have to be in place have to be there for us as dentists as much as an ICU consultant or anybody else on the front line, really. So it's a matter of putting the drill down. I think the dentists did that voluntarily, most of them. We're talking about a date probably towards the middle or end of March. Quite a turbulent period. The news was coming in from across the seas that this thing was going to hit, and it's not a small thing. It's not a rumor. It's here, and it's big. And I think by the middle of March, we knew what was the writing was on the wall. We knew what was coming. At that point, dentists were waiting for guidance. So we were there. We were like, shall we go to work? Shall we be guided by our government? And nothing came, unfortunately, at that time. So we took matters, the majority of us took matters into our own hands and said, look, we're not treating patients. And that's a financial cost to dentists. And we took that decision towards the middle and end of March this year. And we put down the drills, and we've not picked them back up. We've not been going back in, seeing patients virtually as we're doing this now, trying to get them sorted, trying to get them out of pain. And it's going back to prehistoric dental, the prehistoric dental era, really. It's crazy times. I just can't believe the stuff that we're having to advise and say. It's mind-boggling, but we are where we are.
Because a lot of the advice has been around staying away from overprescribing of antibiotics, for example, isn't it?
Yeah.
But you guys find yourself in a very difficult situation as you have to try to manage with the symptoms in the best possible way.
Yeah, and unfortunately, antibiotics don't work for an acute. When you have that acute sort of dental pain, the nerve type pain, they don't work very well. But yet, we know they're not going to work very well. But we have to throw everything at it, and what we're throwing at it is something that can obviously promote resistance to antibiotics further down the line. And patients are just left with something that's second best, third best, fourth best. It's not usually on our list. It's not the first thing that we go to. We either intervene. There's two forms of treatment that we intervene with. One is taking the tooth out if you're in particular nerve pain, or the second is to dress the tooth on the inside to relieve the pain. And those two have not been on the cards for the majority of dentists that are out there.
Okay. Abdul Rahman, I want to come to you. I did mention your title before, and as a restorative consultant. Are you able to just enlighten the listeners and viewers a bit more exactly what your role entails, what it means, or what is your day-to-day job?
Okay, so as a restorative consultant, I work in a dental hospital as opposed to a general practice. And what we tend to see are patients that have been referred in from general practices, known as primary care centres, into secondary care for either more complicated treatments like root canal retreatments that Seby was alluding to earlier on, so taking the nerve out of the tooth. So we do retreatments on those, we do surgery of the gums, we also do more complicated rehabilitation of teeth and missing teeth. My specific role has more to do with cancer patients, so I link up with the maxillofacial surgeons and the other teams that are involved in the multidisciplinary teamwork that is cancer treatment to rehabilitate these kind of patients. And yeah, that's really about what I do. So it's a lot of, it's kind of less general work, more specialized work. Also, there's an element of teaching as well to the trainees and the undergraduates, postgraduates that are on the specialist training courses. So that's really what I do.
And in terms of the work that you're doing now, can you tell us a little bit about what you've been during the lockdown? And you mentioned maxillofacial surgeon. What are the key similarities and differences between your career pathway and a maxillofacial surgeon's pathway?
Okay, so the work that we've been doing at the moment has been limited. We are not doing any aerosol generated procedures as has been advised by the Chief Dental Officer in the beginning. And again, as was mentioned earlier, this is due to restart on the 8th of June, or we're allowed to restart, or it's been suggested we can restart from the 8th of June. In terms of what we've been doing at the moment, we have a rota set up whereby we are seeing our own patients within the hospital setting. So for undergraduate students, there's a large cohort of patients that are basically under their care, under the student's care, as it's a 5-year degree. So you can imagine 5 years of at least 60 students and however many patients they will have individually. So we've had a rota going along with all the consultants at the moment to see any trouble patients or any patients that have got issues. A lot of it has been done over the phone, so triaging over the phone initially via the 3As, so antibiotics, analgesics, etc. And then the other thing we have been doing is we have been taking teeth out as and when necessary, mainly on cancer patients rather than the other sorts of patients. So when they have when patients are having cancer treatment, one of the modalities of treatment is radiotherapy. And in order for them to have the best outcome post radiotherapy, we like to take teeth out before they have that rather than afterwards, because there can be complications thereafter. So we've certainly been taking teeth out for that group of patients, and their treatment has been carrying on. There are other UDCs, which we may come to later on, which have been dealing with the general practice cohort of patients. And in terms of your other question about maxillofacial surgery and restorative dentistry and what's the difference, maxillofacial surgery, you essentially have to have done medicine and dentistry, so 2 degrees, whereas I've only done 1 degree, which is dentistry, alongside a master's, but that was irrelevant. I've also don't do any real surgery. I don't cut tumours out of people's faces. That's more what the maxillofacial surgery team do. They remove the tumours. They do extensive surgery, rehabilitation, etc. So fibula grafts, taking some bone from the leg, putting it into the jawbone, etc. They do all the kind of surgical stuff, and I really rehabilitate the patients afterwards with prostheses, so dentures, bridges, be they tooth supported or implant supported, amongst the other things I mentioned earlier on, like root canal fillings and periodontal treatment as well.
So how have the undergraduates been affected? Because a lot of the teaching and the training's been, has been impacted, hasn't it, due to the restrictions?
Yeah. I mean, well, they've been pretty good, Ryan. They've basically carried on with the teaching has all basically gone online. They already have all the lectures online already, so they still have access to that. So they haven't really missed out in that respect. They have missed out on some clinical work more recently, but that couldn't really be helped. And in terms of the exams have been online, but they are still going to be having the Viva exam for the postgrads, again face-to-face. Sorry, it's going to be online, but it will be in a face-to-face manner, similar to what we've got going on here. So I think they've managed quite well. I don't like to use the word unprecedented, but everything is unprecedented, this situation. And I think the adaptability that the institution has shown to actually get things moving and keep things going has been commendable within where we work. And I think the students are happy with the way things have gone. It might have an impact on the future, depending on how many students will be coming into dental institutions, for example, and other courses. I know that there's talk that a number of students would like to defer their entry for a year, and we'll have to wait and see what happens with that, I guess.
Okay. Seby, I want to come to you. The questions are flooding in already. Obviously, they're quite keen to hear from you both. So let's start with the one. It's a generic one, and it's a topic we would have covered anyways, from Mudassir and Nelson. How can we prevent gum disease, and what are the dangers of gum disease?
So yeah, gum disease, it is largely a preventable disease, not wholly. I mean, there's a slight genetic basis to it as well. So there are certain genes that have been identified that make a person slightly more vulnerable to gum disease. And, some of the statistics are, 30-40% of the population can have that particular genotype. And that results in a phenotype in terms of gum disease. That's how it can present itself. That does not mean that it's inevitable, though, nowadays with modern technology and modern treatments. So gum disease is preventable in the sense that the ultimate source of the inflammation of the gums comes from plaque building up around the teeth. Plaque comes from food that you eat, as well as debris in the mouth generally. Your cells will shed around your mouth, food, just anything that accumulates in your mouth will stick to the teeth. Daily cleaning can obviously prevent that, so that's pretty obvious. Most people know that. They don't know how to do it well necessarily. They know that they should brush their teeth. They know that they should brush twice. They might not know the techniques. But yeah, I mean, general brushing, good hygiene. So interdental care, so that would be in the form of either floss or using little wire brushes in between the teeth, once a day with those. Now, some people don't need to do all of that extensive stuff, but there are a certain select group of individuals, just similar to like you might see certain people that would be very, very vulnerable, and genetically they are very vulnerable to certain things. For example, Asian people and heart disease, and we need to keep ourselves in shape a little bit more than other people. So we try and judge what we see according to what's presented before us, and try and focus our advice tailored to that individual. But generally speaking, it's good brushing, good flossing or cleaning in between the teeth, visiting your dentist. There's certain things that will accumulate. The plaque will over time accumulate, and it'll harden a bit like limescale on the inside of a kettle. And that's hard for you to remove. So at that stage, if you were to try and brush that off, you would be unable to. So that's where the ultrasonic cleaning, so that's a special machine, and it vibrates ultrasonically, doesn't damage the tooth, but yet flicks off this limescale, this tartar, and the bacteria and the toxins within that tartar that are attacking the gums are then removed. And you'll find that the red, pussy, receding gums then become pinker, healthier, they're not bleeding as much, and that's a sign of health essentially. And the dentist or hygienist, as well as what the patient does, is always in dentistry, what the patient does is sometimes far more important than what the dentist does, and what you do in terms of your daily routine.
So we know about the importance of not smoking, not drinking alcohol when it comes to good dental care. But what about the dietary choices that people make? What kind of advice would you give, in terms of anyone who's listening into the show?
So the biggest revelation for people really is that it's not the amount of sugar that you eat that causes tooth decay. So this is it. The two disease problems that dentists usually have to deal with is one is gum disease, and the second is rotting of the tooth. The rotting of the tooth, the process by which that happens is that sugar enters your mouth. The bacteria inside your mouth then actually metabolize that and produce an acid as a byproduct. Now that acid dissolves away anything that's inorganic, that's chalky, like your tooth. So your tooth is made up of a material called hydroxyapatite, and it's dissolved away. That creates a hole, which then gets deeper and deeper into the tooth. But it's not the amount of sugar, it's the frequency of the sugar that's the important bit. So that's the biggest revelation that people have to get their head around. You could eat 100 Mars bars in half an hour if you wanted to, and you probably wouldn't get tooth decay. But yet, if you were to eat one Mars bar every hour for the next couple of months, you're gonna have some serious issues. And people do that. If you look at people's diets and you analyze them, so we give people diet sheets where we say, tell me what you've eaten from start to finish, even if it's a grape that you just went into the kitchen and got a little grape and you ate that. That's important to us because that is a spike in your sugar levels, and it takes about an hour or 45 minutes for that to then come back down. The mechanism by which that happens is usually saliva in your mouth. You've also got enzymes in your mouth that can break things down, and it's washed down by the saliva mainly. And there's buffering capacities within your saliva that allow that to happen, your pH levels to come back up. But the problem is that if you're having one grape every hour, or more commonly what happens is that people are having cereal, which is full of sugar, a fruit yogurt, and some fruit. These are some of these are quite healthy things, by the way. So healthy things like fruit has fructose in it, which is a sugar, and your bacteria in your mouth treat it exactly the same. There's no difference there. And you've got to see that when you look at your diet, you might feel thirsty an hour later, but you're not going to have water. You might have juice instead of water. So these choices that you make a big difference. The frequency of that. If you replace that juice an hour later with water, your pH level remains neutral and your tooth doesn't decay.
Abdul Rahman, I want to come to you. Obviously, say we're down the road now and we've had some decay, and then we come to you, and then things like implants, dentures, and crowns, and all of this sort of thing. Can you give us a bit of a whirlwind tour about what they are and how they actually present, and what you do for these things? What are the differences?
Yeah, I mean, well, the three things you mentioned there are not limited to specialists only. I mean, general dental practitioners like Seby as well will be doing these sort of treatments. So it's something that we all offer. Implants themselves don't fall within a remit of a speciality themselves. It's something we all do. So you asked about crowns and implants. Essentially, if you have a hole in a tooth, it is treated by a filling, and that filling can either be a silver filling or a white filling, as we're all aware of. Once the filling becomes substantially larger than you'd expect, or larger than you could treat normally with a normal filling, you may have to consider what we call custal coverage, where you have something that goes over the top of the tooth to hold it all together, a bit like a sandcastle bucket holding all the sand together. Similar idea there. And that can be what we call an onlay, which sits over the top, or a crown to hold it all together. If you have enough tooth underneath there, you can have a normal a crown over the tooth. If you don't have enough tooth left, and there's been a fracture of the root, for example, or the tooth is not maintainable in any sort of form, you can have an implant to replace the tooth and have a crown on the implant on top of that. Okay, and that's usually a screw. It can be one of two forms: either a screw straight into the implant, so the crown is retained by a screw that goes through the middle of the crown into the hollow screw, which is the implant, and then a filling over the top. Or it can be some sort of abutment, if you will, which screws into the implant, and then on top of that, a crown is glued on, if you will, with a cement. So they're the main types. And again, implants are essentially artificial roots. So if you have a number of missing teeth, you can have an implant either side, and then have a number of units in what we call a bridge. So yeah, they're the main modalities for replacing teeth. Similarly, if somebody has no teeth, they can have an implant retained denture. So they can have a pair of implants in the lower anterior region, so around about here, with little press studs on, similar to a coat, where you have a press stud that just closes together, and the denture has the corresponding component, and the denture just clicks into place there. And they work very well for denture patients. A lot of success stories with those.
Have you noticed any change in the kind of cases that you have to deal with because of the lockdown restrictions? Are people seeking dental help much later stages? Or
well, it's like I said, at the minute, we're not really doing a lot of routine, what I would call routine specialist dentistry, if you will, because we're not getting the throughput from primary care, because primary care is closed at the moment. So there isn't that throughput at the minute. There is still a waiting list, which we're getting through. We'll be grading letters, etc., and ascertaining which ones are the most important ones that need to be seen sooner rather than later, so when we do open back up fully. The main cohort of patients we're seeing routinely at the moment are the cancer patients, because that's the sort of treatment that can't hold for now. It needs to carry on because it impacts upon their actual cancer treatment if they don't have the dental treatment they need.
Seby, we had further questions, so I'm coming back to you again. Hope you don't think I'm grilling you tonight.
No, that's all good.
The next one was on health tourism, and I gather that's a big thing in dentistry, with many people traveling abroad for cheaper treatment, perhaps for teeth replacement, perhaps even whitening or other things, going to Europe, the Indian subcontinent, to name two different parts of the world. What are your main thoughts about it? Do you think it's a threat to you as a dentist working here, and would you look after someone who went there and had a problem coming back?
Yeah, I mean, it's a bit of a minefield, really, and it's a minefield for us as a profession, but I think it's a bigger minefield for patients. Who do you choose? Where do you go? What are your safeguards? What are the insurances? Where do you go if there's a problem? How do you know that you're seeing someone who's qualified, who's regulated? What are the cross-infection procedures like at this clinic? There's a whole host of issues that we deal with in this country as dentists, and we argue with the dental practice down the road. You know, my cross-infection is better than your cross-infection. My qualifications are better than your qualifications. I place more implants and their success rates are better than yours. We can do that in this country and find that there's differences amongst dental practitioners and practices. How do we even start? I mean, me as a dental practitioner, if I was to seek dental treatment abroad, how would I even begin to do that and know what I'm getting? What is the value for your money? Because what we're seeing when we come back, and I think Abdul Rahman will agree with me on this, is that we see some crazy, terrible cases. When I mean terrible, I mean this is like it's shocking. This stuff is falling apart within a couple of years. And not only that, but then you've mentioned, would you deal with this sort of patient that went abroad and they've suffered, and now the practice there is refusing to sort the problem out, plus the patient doesn't want to fly out there, doesn't have insurance for these sorts of things. Do we see them? And on the NHS, you're obliged to, just as a practitioner who, because if somebody had a tummy tuck abroad and they came back here and they were in pain, you would see them. The GP has the Hippocratic Oath to see these people, and we as dentists, we try and do that. The problem is that as soon as you touch something, now we're getting into medical legal stuff here, as soon as you put your finger on something as a practitioner, the saying is that you own it at that stage, even though you didn't do it. So there's a dilemma here, which is, do you perform CPR on the roadside knowing that things could get nasty down the line? And we're very, very defensive as dental practitioners to try and get involved in that case, and sometimes rightly so. So should A, the NHS pick up the bill for that, and B, should the practitioner get involved, knowing that if anything goes wrong, along the way in a very difficult case, that their neck could be on the line, and those are the sort of things that we deal with. So my whole view on it is very, very negative. There are some very, very good practitioners in Europe, and there's some on Facebook that can do much better work than I've seen in this country, that better than I can do by far. But the problem is that how do you find those practitioners? And just because something looks good on Facebook doesn't mean that you then have to go ahead and have that done. I mean, I want to ask you, doctors, this actually. I want to ask you guys a question. I mean, we fall into a category where we're dealing with consumers, not only patients, but consumers. And we deal with pricing. So if a patient comes to us and they say, I can't afford this, we say, okay, what you guys don't have that dilemma. And that's the dichotomy between medicine and dentistry in this particular country. In other countries, it's not as bad, but people pay for their medical treatment as well as their dental treatment. But over here, I think the medical part of dentistry is seen as the charitable part, and that should go along with NHS free treatment. And then there's a consumer aspect to it, which is actually, I want really nice white straight teeth, and I'm willing to go abroad for that. And it's a bit like buying windows rather than sort of getting dental care. So I mean, I'll turn the question to the host, really. I mean, how does it compare to medicine? If a patient came to you and said, I can't afford the hip replacement that you're suggesting, how would you guys deal with that on a daily basis, by the way, with every single patient that walks in through the door? And Abdul Rahman, I don't think you have to deal with this that much, I presume.
No, I don't. But I did do 11 years in practice, so I do appreciate the situation that you're in. Flip side as well is, whilst I don't have to deal with it, I do still see stuff coming in.
Yeah.
Whereby they've been abroad, they said, oh, I don't like the look of this tooth, and then you'll have a whole host of root canal treatments. Every tooth's being crowned, which looks great for the first month. Until you realise that the margins are, overhanging, and then you talked about gum disease. You've got overhanging margins, plaque retention. Plaque retention leads to inflammation. Inflammation leads to bleeding, leads to bone loss, leads to wobbly teeth. So our take on things usually is always less is more. So if you can intervene less and do less actual dentistry on patients' teeth, the teeth will last longer. Every time you take a drill to a tooth, you remove a bit of tooth tissue to make something look a bit nicer. You are committing that tooth to a lifetime of repetitive cycles of replacement of the restorations that you put in. So if it's a veneer, like a false fingernail that goes over the top, once you put that on, you then have to replace it. And there's a whole host of people that say, oh, composite veneers, white film, you don't need to replace them. And I've seen lots of this happening. You do need to replace them. Things will stain over time. Things will need replacing. You need to trim them back down, repolish, etc. So it's the cost, the implications of the cost that you are paying in the first instance will not be that will not be just the one time you pay for them. You will have to pay for them 10 years down the line and 10 years down the line. And each 10 years, let's say they need replacing. So if you have already had your teeth reduced significantly in the first instance, you have significantly less tooth to play with at a later stage, and then you're looking at implants, etc. So from my perspective, I much agree with Seby in terms of health tourism. I don't advocate it at all. I have seen the fallout of it. And I do think that if you're going to invest in something, invest in someone who has invested in themselves and spent the time investing in their ability and their capabilities. And if you wish to have something done, as I've advised people before, don't go and get it done abroad, because you're not going to go back abroad to have it fixed later on. And no one will touch you here once it's been done abroad. That people are very reluctant, as Seby said, to touch other people's work. And usually it might just be pain management.
And just to add to that, I mean, I'm speaking negatively, and you introduced me as somebody who does cosmetic dentistry, and I do cosmetic dentistry quite a lot. I mean, it's a decent bulk of my work, but I say that with real caution. So whenever a patient comes to me, the consent process, as we all know in this in this group chat, is very, very, very important, and that consent process can differ. So I'll tell you a story about a patient of mine who I plan to align teeth and whiten their teeth and just do tiny little white fillings on their teeth. So align them, whiten them, and to put tiny fillings, white fillings on. And it's quite a common procedure now in the UK. And it's a very, as Abdul Rahman was saying, it's to invade the least amount that you can invade the tooth tissue, the better it is in the longer term. So that's it's not a very invasive procedure, the whole thing there. This patient, halfway through the orthodontic treatment was complete. I was ready to whiten them. I'd whiten them. I was ready to put the final fillings on, the final touches. And the patient probably looked at Love Island on TV or something, decided to go to Turkey, and came back with crowns all the way across from here, from his upper left molar, all the way across. Unbelievable crowns. And I asked him what happened, and he said, look, I just wanted them to be absolutely perfect like they're on TV. And I said, look, we hadn't finished the final product yet. And he thought that he had veneers done. Now, veneers are just a shell on the front of the teeth. They're less invasive than a crown is, which shaves the whole tooth down. When I asked him what he had done, he said veneers. But when I looked in his mouth, he actually had crowns done. And that came as a shock to him, because the consent process had not been followed. So if I'm going to do something on somebody, I've got to make sure that they understand exactly what they're getting done. And as Abdul Rahman said, the long-term implications of that. If after that they're happy, I'm okay to go ahead with that. I'm comfortable with going ahead with that. We all have red lines, though. As practitioners, we all have red lines, and those red lines are slightly different. But I think it's good to be realistic to patients. In the longer term, it's a dangerous territory, and I do that. The reason why I do it is because there's an element, and I've said this to Abdul Rahman as well, which is how much can you value aesthetics? If that person is more confident in going for job interviews, if that person has more confidence in relationships, if that person is a different person on the other side, then is a millimeter of tooth tissue worth that sacrifice? It's more of a moral dilemma than it is a scientific dilemma, and that's one that I can't answer. But what I'll do is I do gauge the patient, and I say, well, actually, in this case, I think it's a no for me, and it's more of a no for me than it is for them, and it's my red line that's crossed at that moment in time.
So I think I'd agree with Seby. I mean, two things I'd like to say, just to qualify both statements that we've both been making. We've kind of inferred, I mean, Seby's already qualified this, but, we've inferred that, a lot of the time the treatment will be substandard abroad. That's not always the case. I have had a patient when I was in practice who did go to an Eastern European country and had fantastic work. The only thing I would say is one bridge, I wouldn't have done it that way. But again, that's subjective rather than definitive. Other than that, the implant work was fantastic, but it is a bit hit and miss where you go. There is no relation, no rapport, no. You're completely. You're going in essentially a bit blind, having done a mild bit of research, based on what they look like on the photographs on the internet. It's a sales pitch. I think the other thing I'd say is I completely agree with Seby in terms of the whole kind of beautifying nowadays. Seby, alluded to a case that he treated. I mean, a number of years ago when I was in practice, I had a young girl come in. She couldn't be more than 19. Looked fine, no problems with her at all. Teeth all looked fine. Came in with a mother, and she wanted veneers. The teeth looked fantastic. There was no problem with the teeth, but she wanted veneers. I've seen veneers. I want veneers. I'm sorry, I'm not going to provide you with veneers. Explained everything. Explained why. Explained the risks, etc. At which point she broke down in tears, and said, "Well, I'll find someone else to do it then." And she probably will find somebody else to do it, But I think that this is currently a big issue at the moment. It's an issue with cosmetics, aesthetics, people having expectations that their life will be so much better if the teeth are better, and in some cases they might be. In some cases where they're justified to have that. In other cases, there's people with negative. You'll probably be aware of this in your fields, respectively. People having these kind of expectations that their life will be so much better when this is have negative ideas about their own personality and their own presentation, which is not there. So I think, you know, it's difficult now because of all the media and the social media side of things. People competing and people wanting to look better. You know, everybody being 6'2", chisel. You know, it's not the real world.
Yeah, that's the world. Unfortunately, it's the world that we live in now, isn't it? So we have to succumb to those pressures somewhat.
Or we don't, as we haven't. So
yeah.
I think I am mindful, Seby, we haven't actually answered your question.
Yes,
So
I want you to answer the question.
yes. So I guess as you know, I'm a psychiatrist, and sometimes we do get referrals from private psychiatry care. Let's say a typical example being someone who's depressed, who may well be recommended for ECT. So ECT is electroconvulsive therapy. And sometimes the practitioner will refer to the NHS because it's actually provided free if you meet the criteria. So sometimes they actually don't need the ECT. But then it just becomes a very difficult conversation, as you guys obviously have had to have those conversations. People do seem to think NHS is a very, accommodating, encompassing kind of service, but we do have to kind of safeguard as well. Sometimes it just involves a conversation. So I guess I'm lucky that I can have a conversation with the private practitioner because it's UK based, whereas you guys can't exactly pick up the phone and speak to someone in Budapest.
Yes.
And have that dialogue in terms of what have you actually done, why have you done it this way, and what's is the patient aware, etc., etc. It's a difficult issue, but it's an issue as consultants, as leads in our practice, we all have to try to deal with. And the key thing is communicate with colleagues and make sure what you're doing is the right thing. But you both did touch on aesthetics, and this is something that we do want to cover after the break. So bear with us. We're just going to be off for about 2 minutes, and then we'll continue with the conversation. Thank you for watching and listening. Right, and we're back. Thank you, everyone. You're back to MEDtalkx. We're talking about everything related to dental care, and we've been blessed to have Seby and Abdul Rahman giving us their thoughts and expertise. Faheem, what's on the agenda for the second half of the show?
Well, it's going to be constrained now as we've short on time, but there's quite a lot we want to talk about, a bit more on teeth whitening, your top 3 tips and so on. But Seby, I think it'd be neglectful if we didn't talk a little bit about children's teeth and the pediatric population. I know a lot of people when they're younger, they find it anxious going to the dentist, and maybe with the coronavirus. So maybe we can tackle it in one go. How do you alleviate anxiety for children or perhaps adults who come to see the dentist, and also with the pandemic, who are putting off their dental appointment and not phoning up the dentist? If you can take both questions and angles in one go.
I think there were 3 there. First of all, it was children's teeth, and then there was the anxiety. And then the last one, what was the last one again? Sorry, there were 3. Yeah,
so it was the children's teeth, the anxiety about going to see the dentist, and also actually ringing up the dentist now in a pandemic.
Yeah. Children's teeth, this is something that's really a black mark on dentistry in this country, I would say. I think the number of hospital admissions last year, somewhere around 30,000. I think that's off the top of my head, somewhere in that. So I know for sure it's the number 1 reason for hospital admissions for children. For sure, it has been for a very long time. It's increasing as well, so it's not going down, and it's largely a preventable disease. I think it costs probably about 30-40 million pounds a year at least on the NHS. I did have some facts, but I think that's pretty much what it is. Why is that? There's probably lots of reasons for that. One is education of the parents and the children themselves by default. The other is sort of incentivizing healthcare professions by remuneration. We're going to talk about money hopefully at some point, because it's an important part of it. If you don't pay your dentists or your doctors or any other health profession to be able to sit down and have a conversation, if you keep them on a treadmill which is running at 100 miles an hour, for them to chase targets which are not relevant to prevention, then you're going to have outcomes where people neglect their teeth. And that's pretty much what's happened over the last 10, 15 years. You've got things like, should we have things like a sugar tax? Should we have, there's many wider socio-economic reasons why these things happen, not related to dentistry. They are, much wider than that. Socio-economic reasons. Your choice of food when you go to a supermarket, is it full of glucose, fructose, and corn syrup, or is it something that's healthy and nutritious and good? So there's lots of socioeconomic reasons why those things happen. In terms of anxiety, again, we come in the top 5 of probably anxious episodes that a patient ever encounters in their lifetimes. Spiders amongst them and various other things. But we're in the top 5, I think. Things have changed. I want to reassure people that things are normally based on what happened by what we term the school dentist. These are dentists that were butchers for their times, I would classify them, but maybe that was the norm. And people went in and they were held down and things were done out of force. Things are not like that anymore. The majority of dentists out there are very, very good at sort of alleviating patients' fears. They understand it. It's nothing to be embarrassed about. When you walk into the dental practice, they've seen it 100 times before. They've seen teeth that are 100 times worse than your teeth. They've, they don't care about bad breath. They don't care about these things. They're used to it. It's part of their job. And a good dentist really will talk in a manner that doesn't speak down to a person, that appreciates where they've come from, that understands where they want to get to, and really rides out that journey with them, and says, look, this is where we were, a week ago, look at where we're at now, and does things at the patient's pace, not at the pace defined by their remuneration or by governments above them or by a treadmill that they're stuck on, unfortunately. I hope that that's not the case, because you've got to treat people as individuals, and they will value that. We call that goodwill. They have goodwill in the practice. In terms of COVID, you've got to get in contact with your dentist at this moment in time. Ring your dentist. Dental practitioners, the NHS practitioners at this moment in time, they have a duty of care to keep their not their doors open, but their telephone lines open in their normal working hours. They should be able to answer any of your queries. They should be able to treat you according to the AAA principle, which is obviously at the moment antibiotics, analgesics, and advice. Not ideal. And if it works for you, brilliant. And if it doesn't, they can then refer you on to what we call urgent dental centres. Now, these urgent dental centres, unfortunately, have been very slow off the mark to be created. They don't have the right PPE. This is a word that Joe Public finally knows. I mean, we've known about this for a long time. Joe Public knows what PPE stands for. So that's personal protective equipment. They don't have enough, or they don't have the right stuff. So the care that you will receive is kind of ad hoc. It's not consistent across the board, and certain procedures are limited. There's certain mistakes that I think were made politically along the way. And I think that we should all have had. I've got PPE sitting in my surgery right now, which is fit for purpose, and yet I can't use it. I've got the same operating procedures, the same safety measures that these urgent dental centres are, but those urgent dental centres have been defined by the government, and I'm not allowed to open my surgery to help those people. They have to be helped by these resources, but the resources are not at where they're needed, essentially. So, but your dentist hopefully can point you in the right direction. Analgesics and advice first, pass you on to an urgent dental centre. By next Monday, the 8th, is a crucial date. Most dentists can open their practice on limited treatments with new measures in place. Visiting the dentist over the next year or two probably will not be the same as what you visited before. So there's new protocols in place. So you have to get your head around that. Just like seeing a GP now is usually over the phone in the first instance. But there's a lot of measures in place, things that look very different nowadays.
That's a very comprehensive answer, Seby. Thank you for that. I guess because you guys are practicing in an aerosol generating environment, you need a certain level of protective equipment, don't you? FFP3s or something equivalent, as opposed to a typical surgical mask. Which
now we're going into the depths of PPE, which is FFP3s, FFP2s, So this is different levels of filtration of the air that the user will receive. So the how clean will the air be once they recycle. Now, in terms of AGP, there's a big debate within the dental community. I have to tell you now, aerosol generating procedures. I don't know if your viewers are familiar with this, but that is anything that produces an aerosol. An aerosol is almost like a puff of liquid, a cloud of liquid, so to speak, in the air, which lingers in the air as well. Now, you may think it's obvious. Surely coronavirus is spread through this mechanism. People cough and then they pass it on. That's how it spreads. But it's not so obvious, actually. The data is showing us that it's not so obvious that it spreads by this means. Splatter is something completely different. That's almost like a ballistic missile of spit, so to speak, that goes across, lands on something else. Someone else then touches that and then puts that in their mouth or their nose or touches their face, and it gets spread that way. We know that coronavirus definitely spreads through splatter, but does it spread through this cloud of smoke, this cloud of liquid, so to speak, called aerosols? Now, the debate on that is not over. It seems like dentists who have not been using FFP2s, FFP3s, and have been working as normal across the globe, they don't seem to have an increased death rate. We don't know enough about the virus at this stage because it's still very, very early days, but we are taking precautions against that. So the dentists are using FFP2s, FFP3s when they can find them, and we're taking those precautions. So we're taking precautions above and beyond what the data tells us, what the evidence tells us, but the evidence is sparse, unfortunately. It's limited at this moment in time, so we just have to take all precautions that we can. But is it spread by that? We don't know particularly, but it doesn't seem like it's one of the main vectors. But we're doing all sorts of measures. We're cleaning the air room, the room of the air. There's distancing. There's allowing the room to settle down in between patients, all which is slowing down dental practice and is a big financial hit to dental practices. And you may find that there are not as many dentists around financially, unfortunately. A lot of them are going to the wall at this moment in time. It's a big crisis within the dental community at this moment in time. Hard time.
Well, I know listening to you, Seby, that I'd be very comfortable being your patient. You've definitely made me feel comfortable going back to the dentist whenever that may be. You mentioned finance and remuneration a few times. So I'll take that with Abdul Rahman if you can. I know off air we discussed this letter by the British Dental Association that was written to the Chancellor about support for self-employed workers in the dental industry during this crisis. And I think Seby sort of alluded to it regarding financial help for the dentists, because not all of them perhaps actually earn as much money as some portions of the public think. What do you think about the letter, Abdul Rahman, that was made by the BDA chief executive to the Treasury? And what are your thoughts on the financial situation for dentists? Are they struggling at the moment financially?
Well, the question is probably best answered by Seby, but I'll give you my answer because Seby is actually in a practice setting and I'm in a hospital setting, so not really impacted upon me very much. However, that said, certainly the private practitioners will have been struggling, depending upon how much they put away for a rainy day. The private practitioner's income is based usually largely, or in fact entirely, on patient fees that the patients will pay themselves, whereas the NHS or mixed practitioners will have a mix of both NHS funding from the government and also private fee-paying patients. So yeah, I'm certainly aware that the private practitioners have had a bit more of a rough deal in this time when they've had to be closed at the moment. Generally speaking, it can be assumed that a private practitioner will earn more, or it's assumed that way that they'll earn more than an NHS practitioner. But again, that depends on whether that NHS practitioner is an associate, whether they own the practice, how much the contract value is. There's a lot of variables there. And I think, Seby, you might want to chip in on this and give us your opinion of what's been going on. We've been on the cold.
If you look at the data, one is the public perception of what dentists earn and things like that. And I think going back, we've had a good time historically, but things are much, very, very different now. NHS funding for dentists has largely plateaued, and costs have risen. So that, in business terms, equates to one thing: it's a squeeze, isn't it, on the profits? And dentists have been regulated, so they've really been pinned in the middle. And I don't want the violins to go, but essentially what's happened is that you've had regulation and you've had patient pressures, so patient expectations, and then you've had costs which are rising, as well as a multitude of other sort of pressures and factors that have led to the profession not being the same as it was. So anybody coming to work experience will hear that from me as soon as they walk in through the door, which is, have you thought about plan B? Unfortunately, I'm having those conversations, which is think about plan B very, very carefully. In this country, dentistry is not the same occupation as it was. So if you look at the dentists and how much they earn, an NHS practitioner can earn the same amount as a private practitioner. And across the board, NASDAL, who do our accounts for us, they'll tell you that the figures are very, very similar. And the only difference between it is that a private dentist like myself, I'll see one patient every half an hour, one patient every hour, one patient every hour and a half, whereas an NHS practitioner might have seen 3 times that figure. So the funding is smaller, the amount that's coming in is smaller, but you're seeing a bigger volume of patients. But I prefer to work in a slow manner, a methodical, and that's, I can't do the NHS type work in that respect. I can't work under those sorts of pressures and those systems. I choose not to. But yeah, they really are struggling. Not only that, NHS practices will be struggling. They can't afford the PPE. If the NHS funding has stayed the same, PPE costs have risen, you've got a much tighter squeeze. Plus, the amount of turnover of patients is reduced. It's going to be reduced for private practice as well as NHS practice. So there's a big problem with dental care, and in terms of keeping it viable, these people are up against it now.
I think this isn't a short-term thing. This has been a long, ongoing thing. I mean, I qualified in 2003. In 2003, much in the same way that it is in Scotland now, fee per item, you pay for what you have. You have one filling, you pay for a filling. You have 2 fillings, you pay for 2 fillings. There was a set limit upon which basically that was the maximum patient expenditure. Beyond that, you'd have to submit a claim to the dental practice board. They would say yes or no as to whether or not this treatment could be done. After you put together a plan showing models, x-rays, X, Y, and Z, say this is what the patient needs. They would then yes or no it, and you would be assessed periodically by the dental police, essentially, that will come and see your record, see the patients, etc., and see what's been going on. 2006, that will change to units of dental activity, whereby you get paid the same for doing 1 filling as you do 5 fillings, 6 fillings, 10 fillings, £1, 5 crowns. So the actual value for the patient seems to be better, but it's probably not in real terms, because the quality of the stuff they're getting back from the labs, etc., will be of a lower quality metal, etc. The time that the patients have with the dentist is less. You GPs know that. How much time do you get to spend with your patients compared to, what somebody had 20, 30 years ago? It's the squeeze that everybody's feeling at the minute. It's not just in primary care, it's in secondary care. The squeeze is all over the place in the NHS at the moment. And I just think it mustn't be seen that private dentists are those that are money-grabbing, lucrative dentists. They're those that like to spend a bit more time with the patient, to provide the level of care that they'd like to provide, and they would like to receive themselves. So that's how I see it anyway. And those that are within the NHS may be stuck within the confines of the NHS in primary care. I don't know. They may like that kind of service. Who knows?
I guess I am mindful of time, because an hour is nearly flown by. Thank you so much for coming on, discussing everything that's relevant around dentistry. I guess for everyone who's listening and watching, I just hope you heed the call that don't take dentistry and in essence your teeth as a very symptom orientated approach. So actually get some regularity, retain those relationships with your dentist, be proactive. We will try and put some links and some additional guidance as to what you need to make sure that you have in your bathroom. Unfortunately, we didn't exactly get to that because of time restrictions, but I'd just like to thank Seby and Abdul Rahman and again on coming on the show.
No problem, you're welcome.
Guys, before you go, we always ask as a tradition, top 3 tips for the audience to take away. And in time-honored tradition, Seby, what are your top 3 tips in terms of general dental advice to a listener or viewer tonight that is going to make basically the most effective use of their time and resources?
So I'm going to apologize. If I go first, then Abdul Rahman is probably going to repeat exactly what I'm saying. I would let him go first, but I'll take the helm. It's very, very, very simple. It's so simple. Okay. So the frequency of the sugar, we talked about that. So just knowing what's got sugar in it and what hasn't. Okay. So that is it, and it's the frequency of it. So keep it to your meal times. In between, if you're thirsty, have water. If you need to have juice or something, keep it to your meal times. If you need to have grapes, keep it to your meal times. Any fruit juices, any chocolates, biscuits, keep it to your meal times. In between, if you're peckish, pick savory snacks. So things like nuts and olives and toast, cheese, whatever. So savory snack. So frequency of sugars. 2, brush your teeth and look after them. So a bit of hygiene, brush your teeth, do it methodically, 2 minutes, 3 minutes, and something in between the two if you've got time to do that as well.
That's specific advice for Faheem there.
Look, I brushed them for you, Seby. Look, that's my smile line.
It's great. It's great. It gives you character. And the last one is visit your dentist as frequently as they recommend. It might be every 6 months. It might be every year. Just go and visit your dentist. Make sure everything's in good order. And really, if you follow the first 2, you probably don't need much of the third one. To be honest with you, all it's a preventable disease. Sorry,
Abdul Rahman.
Sorry.
Yeah, I mean, you got the hard shift going second there. But so just to recap, he mentioned obviously regularity of sugars with meal times and regular brushing at least twice a day. Some of the newer brushes I think have a timer even to help you out, so you know if it's 2 minutes are up. And also he mentioned visiting the dentist regularly, which will be different now in these times anyway. So Abdul Rahman, what can you add to that? Any other 3 tips for the audience?
Yeah, there's a lot of talk about fluoride being toxic and all we want to avoid fluoridated toothpaste. I would stick with the fluoridated toothpaste because it's actually more effective. It's not bad for your health. Don't eat it and you'll be okay. Just brush with it, you'll be fine. Eating it can cause problems. In terms of children, you talked about those earlier on, and anxiety. I've often seen before in my practicing career, a lot of the time the children are absolutely fine, but the fear of the dentist is thrown into them by the parent by saying if they don't brush, you'll go and see the dentist. We'll send you to the dentist if you don't brush your teeth, all that sort of stuff. The dentist isn't a nasty man. That fear doesn't need to be invoked upon the kids. And actually, by bringing them at a young age regularly, they will be fine. They'll get used to the smell of the place and they'll get used to it. And if it's made a fun kind of thing, Peppa Pig, for example, is a fantastic advocate for going to the dentist. Let them watch that. That works quite well. Third one, you talked about brushing and toothbrushes, manual versus electric. Doesn't really make much of a difference if you've got good manual dexterity. Electrics are better if you have less. I mean, the dentists, we generally have good manual dexterity, so for a dentist group, it doesn't make much difference. But for Joe Public, electric are better. Timers, you said, yes, some have timers. Peep alternative, egg timer. That's really bad. I think routine visits to your dentist to assess for the stuff like gum disease, decay, etc. And more importantly, from my perspective, or more drastically, oral cancer. Sometimes patients don't appreciate that's what we are looking for as dentists. We look for dental disease as well as cancer and stuff like that. And a prompt referral can often result in a better outcome for a patient than those that are smokers, drinkers, as that's the main cause of cancer, who don't attend the dentist regularly. They're the ones that will tend to suffer more if it's not spotted early. So a couple more than 3 maybe, but all together bunch up as 1.
Yeah,
that's okay. We're not going to mark you down on your maths. It's fine, Abdul Rahman. So great. I think that concludes the show. And basically, warm thanks to both of you for giving up an hour of your time on a Tuesday night. Seby and Abdul Rahman, it's been great catching up with you both, giving us wonderful advice. We've had lots of feedback as the show's been going on as to how wonderful it is. And we may actually have you back again at this rate. So that's really good to hear. So I want to thank you again. And just for